And welcome to the Wavy Digital Desk. I'm here today with EVMS to talk about Breast Cancer Awareness Month. Dr. Rachel Burke is going to be joining us to discuss what you need to know, some of those tips to leave out, the end of the month with. So I'm just going to bring her on. Dr. Burke, thank you so much for joining us today and taking time out of your practice to sort of talk to us about what people might need to know on a different platform here at the Wavy Digital Desk. So I really appreciate it. I mean, can we just get started by talking about what your background is in the field?
Sure, thanks for having me. My training is in surgical oncology, cancer surgery. So I do all sorts of cancer surgery, but I do focus on breast cancer quite a bit here at EVMS and in partnership with Centera.
And, in your practice, I guess, the thing is that I guess people are curious about. I feel like everyone has a friend, a neighbor, a loved one, unfortunately, whose lives have been touched by breast cancer. But I guess, just to start, and I think screening is a big thing that is pressed this month. So I just want to start there. How important is that regular screening?
Right. I would say it's really has made a huge difference in the last 40, 50 years. Certainly in my lifetime, the survival rates for breast cancer have improved dramatically. And I think screening is a big part of that. Early detection makes breast cancer far more treatable. And so screening is the way to go.
And is that screening, is it important just because it catches individual things in each person's body? Or is it also important just because, I don't know, is that the best way to really see, besides blood work and other things, that breast cancer is there?
So blood work hasn't really been shown to be very helpful in terms of detecting a new breast cancer. We use some blood tests for following patients with cancer. But in terms of screening, really, every woman is at risk for breast cancer. And what we're trying to push is for women at younger ages, certainly by age 30, really to risk stratify women, because obviously we want to individualize care. And if you are at average risk for breast cancer, then we recommend starting screening at age 40. However, if you have a significant family history or other risk factors, you would really benefit potentially from screening as early as 25 or 30 and incorporating not just mammograms, but MRIs or other imaging modalities in terms of detection. So we really try to individualize it and really push to have the conversation earlier with patients so that we can set them on the right path.
Right. So, I mean, I guess if you aren't familiar with your family history or you're not thinking about that, that is something that maybe is one of those first things that you really need to ask yourself, the earlier, the better.
Yes. A lot of families and patients don't talk about cancer and don't want to share these things, particularly in some cultures. It's just something that isn't discussed. And so you can't necessarily force that discussion in the family, but again, awareness is key. Sitting down with your primary care physician and having that conversation, and then that, if you bring that back to the dinner table and talk to your family, hey, my doctor said I could be at risk. Can we talk about, what's gone on in the family, those kinds of things. But family history is one part of it. And certainly that's something we think of most when we think of high-risk patients. There are other risk factors as well, and some that we can change and some that we can't change. Family history, of course, being one of the ones that we can't change. There's patients who may have had radiation for other types of cancer when they were teenagers or younger, and that may increase their risk for breast cancer. So there's a lot more to it that you might not think of right off the top of your head.
And what are those other factors that might put you at risk? Or is there a way to, I know that there are certain tests that can sort of see if you have those genes. I mean, what are some of those things?
Sure. Well, there's genetic testing, which again, we usually are, that is prompted by family history. And then we break risk factors down into two big categories, those that you can change and those that you can't change. Alcohol, smoking, being overweight after menopause, some hormone replacement therapy around the time of menopause, So those things can increase your risk for breast cancer. And so again, it's all about knowledge. You know, changing that later in life may not be as effective as changing it earlier in life, but we all have to start at some point.
And a big thing we hear right now is that it's almost progressed not too late but too much for you to have, you know, a physical exam and notice a lump or such in your breast. Is that something where you want to get screened earlier on so that, you know, you don't get into that territory of maybe actually getting, you know, larger cells or a larger, you know, tumor or something like that?
Sure. So certainly we'd like, the whole point of mammograms and breast screening is to catch things before they're big enough to feel them. But mammograms aren't perfect. They can miss some cancers. And so, you know, if you feel something, don't blow it off and think, well, it's probably nothing. I just had my mammogram. If it's a change, then, you know, it's worth getting evaluated, because there are other tests we can do other than mammograms if there is something else.
And with mammograms, you know, you hear about 2D, but also 3D mammograms now, if you're able, and if you're, you know, medical sites. We're lucky down here that I think there is a lot of access to, you know, newer technologies. But can you just explain, I mean, is it really that big of a difference with that 3D? And if you are able to have it and have access to it, is that the test really that you should be looking at?
Yeah, I think 3D mammograms are the way to go. I had a conversation with one of my colleagues in radiology recently about this, and unless you have very fatty breast tissue, if your breast tissue is at all dense, and many women do have very dense breast tissue, then 3D mammograms are really the way to go. So basically, a 2D mammogram just takes one picture of the breast, well, two pictures, one in each sort of sideways and up and down, whereas 3D mammograms take multiple slices, if you will, throughout the breast. So we get a closer look at the breast tissue. And it, cost-wise, the majority of insurance companies will cover 3D imaging, so it really shouldn't translate to higher costs for the patient. 3D mammograms have been shown to have a higher detection rate of cancer. And they also have a smaller, lower, what we call false positive rate, an abnormality on imaging that turns out to be non-cancerous. So I think really the standard of care is becoming, and in this area really is for the most part 3D mammograms. There was some concern about higher radiation with 3D mammograms, but with the newer technology, it's not significant.
I was going to ask, so sometimes, you know, you hear that people are worried about getting these scans because they don't want to risk themselves, you know, to getting cancers or any other thing. I mean, is that a myth really? Is that just a fear, or?
I don't think it's a myth. I think in the previous technology, there was higher radiation dose with the 3D imaging. However, with the newer technology that the radiologists use, it's not significant.
And then, you know, speaking of sort of these newer technologies, so like 3D, which now is really routine in some places, are there any new developments or anything new that you all are using or seeing used in your patients to help with, you know, either breast cancer treatments or with breast cancer screenings?
Sure, I'd say it is such a rapidly, constantly evolving field, and there's always new things. There's, in terms of surgery, actually, you know, we do smaller and smaller surgeries, but still have just as good outcomes. You know, 50 years ago, everybody might have had a mastectomy with lymph nodes removed. In this day and age, we do a lot of what we call breast conservation, just lumpectomies and preserving the breast. For patients who need mastectomies, we can save the nipple. We can, there are a lot of different ways to do reconstruction. So that's, from a surgical perspective, it's always constantly evolving. I think the more exciting changes in more recent years has to do with the medical oncology side of things, and not just the chemotherapy, but the immunotherapy that is now used to treat breast cancer. And we use a lot of treatment up front before surgery, whereas we used to always do surgery first. And now we see that a lot of these newer therapies are really completely killing all the cancer cells. And so we know that means a very good prognosis for the patients who have what we call a complete response to their chemo or immunotherapy. So that's really been a big boon.
Right. And then that works better for you all surgically, for as much cancer to be removed as possible really beforehand, right?
Exactly. So we can use that treatment up front to shrink a tumor. Even if you come in with a big lump, we can shrink that down to almost nothing or next to nothing. And then we may be able to do just a lumpectomy, whereas had we operated up front, it would have been a complete mastectomy potentially. So that's been really helpful for us.
And then that, personally and both physically is a very difficult surgery, I'm sure, for patients.
It is. It is a very individual decision in terms of, anybody with breast cancer really has a choice between a lumpectomy or a mastectomy. And it is very much an individual decision. There's a lot of fear and stress in any cancer survivor. Every time if a woman has a lumpectomy, we still do obviously mammograms to follow up, and they're at higher risk for another breast cancer down the road. So there are women who, even though they have an early stage breast cancer, might opt to have a mastectomy for that reason.
And age, I guess, is important here because I think your decisions look very different when you're younger versus when you're older. And then depending on, if you're looking to have a family and what way that looks. But I mean, for your patients, I guess I'm curious, now that the screenings are getting younger and earlier, are you finding that, I don't know, I mean, I guess I'm curious what you're finding, with the screenings earlier. Are there more people coming in with breast cancer that are younger now that screenings are getting earlier? Are people coming in and, they're having maybe lower stages of breast cancer? I mean, are you seeing changes with the screening guidelines at all on your side?
That's tough to answer. There've always been young women who get breast cancer. I've seen quite a few lately, some in their late 20s and early 30s, and you're right, the decision making certainly is different depending on where you are in the stage of life. I don't know that we're necessarily seeing a difference right now in terms of the earlier screening. I'm sure it's in evolution. I don't know the data on whether we've had a big shift. I mean, the peak of breast cancer diagnosis is still in around age 70, 60s, and 70s. So it's certainly not common in the younger women, but again, and those women tend to come in with a lump that they felt. So it tends to be a little bit bigger than we would have found on screening imaging.
Right. And then, I guess for those women that have breast cancer are looking to, figure out what's the best option for them. I mean, is it really going to your primary care first? Is it sort of getting those routine checkups, checking yourself physically? I mean, I guess I'm just curious, what are the best things for people to do to give them the best shot possible for that early detection?
I think keeping up with annual mammograms. If you hit age 40, then we recommend getting a mammogram once a year. There was a lot of, obviously, COVID put a lot of people off track, but we're getting kind of back into the regular routine of all these screenings. And then again, knowing what your personal risk is. And if you do have a strong family history, then you should talk to your primary care doctor about a referral. Centera's opened a number of high-risk breast cancer clinics, really, in trying to identify those women at high risk so we can get them into the screening programs earlier. And we actually look at those women not just every year, but every 6 months and alternate MRIs and mammograms for those high-risk women.
That's great. So, they're going off a different schedule than that annual year.
Right.
Well, Dr. Burke, I mean, is there anything else that you sort of feel is necessary, I guess, in this month of awareness where, things are resources and information is widely available, but I guess is there anything that you really want to make sure is known sort of in this month or I guess going forward?
Well, I guess I would just say we want to support everybody who's at risk, and that's really every woman, even women without insurance or not great access to care. We have free clinics available where we can get them in for their screening mammograms. You don't necessarily need to go through your primary care to get a mammogram. We can just, schedule that for you. So that's step one, is just getting screened and getting your foot in the door and getting on a regular program.
Great. Well, Dr. Burke, thank you so much for your time and answering some of these basic but very important questions, I guess, rounding off the month. So we really appreciate your time, and thank you so much.
Thank you. I appreciate being here.
Thank you.